Good evening, everybody. It is a very honor to myself to introduce the three eminent speaker and the eminent moderator. I will introduce Dr. Khalil Allah Shibli. He is going to be the chair of this session tonight. Dr. Khalil Shibli is graduated from College of the Anesthesiology in UK, and he got a degree, master degree from Maastricht, and he finished his training according to the UK standard. Currently, he is a senior consultant anesthesiologist and pain medicine and ICU and the perioperative medicine Hamad Medical Corporation in Doha, Qatar. Is not only that, he is associate section head of the anesthesiology department in Wakra Hospital. He is the site director of International Anesthesia Residency Training Program in Al Wakra Hospital. He's a member of the co-faculty and the Clinical Competency Committee in Anesthesiology Residency Program in Hamad Medical Corporation in Qatar. He's a member of Research and Audit Committee in Hamad Medical Corporation and Anesthesiology in Qatar. Dr. Khalil Shibli, we have an honor to have him tonight, and I will leave the session for his chairmanship. And just to remember, all the action tonight is absolutely in English language. If you wanted to have any comment or any question, directed to Khalil Shibli, Dr. Khalil Shibli, and he will take the question to the each speaker after each session. All yours, Dr. Khalil. Thank you very much.
Thank you. Thank you very much, Dr. Saad. All the speakers and the participants, hopefully you can hear me. And first of all, I'd like to thank Dr. Saad, yourself, and Mega Medical Association for inviting us as a group from Qatar and present some of the knowledge or share some of the knowledge. So some housekeeping points for the audience and for the participants, please, that kindly keep your mics muted during the presentations, and they can write, they can do chat, they can write question and answer sessions, and I will present one by one our speakers, eminent speakers, experts from Qatar. In fact, in the region, really, if I may say so. Now, we're going to move on to last but not the least, our young speaker, Dr. Mohammad Al Nobani. And I'm going to present, before I present Dr. Nobani, can you come onto the screen, main screen? Can you bring yourself onto the main screen? Yeah. And I'll let the audience know that Dr. Nobani is a young clinical fellow of pain management in the fellowship program, actually, for the Hamad Medical Corporation, and the current chief fellow of the Anesthesia Fellowship Program. So we have several fellowship programs ongoing at Hamad, and he's the chief fellow of all the Anesthesia Fellowship Program. He's the head of technical support at Qatar Difficult Airway Society, so his involvement is elsewhere. He's completed his anesthesiology residency program at HMC in 2017, and this residency program, I must say, is the ACGMEI, the first ever of the Middle Eastern international program. He has passed his Arab board. Everything he has done timely, and he has got a European Diploma of Anesthesia and Intensive Care, and he has European Diploma of Anesthesia and Intensive Care and Postgraduate Diploma of Intervention Pain Medicine from France. He has won multiple awards, including, I would say, second place, a very good place for the best proposal surgical research and innovation ideas, which is held in Doha every year. It's the Surgical Research and Innovation Ideas Conference Symposium. He received the best proposal on the technological track. We have two tracks. One of them is the technological track. And then the project is Q-Teach Individualized Learning Plans in Busy Clinical Settings. He has won recently the HACC COVID-19 hackathon with his project of the mask piece, and he has been nominated as a Spark Innovator in World Innovation Summit of Health Year 2020 WISH, WISH, which is an abbreviation. He has multiple book chapters and publications, multiple research publications. He is an instructor in the ultrasound guided chronic pain workshop, advanced airway workshop, and the basic airway workshop. And above all, this young man was inducted as a fellow. I remember by myself when I was the chronic pain fellowship director 2 years ago. And he has progressed very well, and I'm following his progress with an immense interest. And now he's sitting somewhere in USA. Where are you, Nobani?
And I'm currently in Ohio.
Ohio. And what's the
Yeah.
time difference now? Tell us, what's the weather
Uh,
like?
what seems to be there's a storm outside, honestly speaking.
Storm, okay.
It's midday right now. It's around 2 o'clock.
Around 2 o'clock. So
Yeah.
yeah, okay. So now, without further delay, I let you take away. Maybe it's a continuation of Dr. Yasser's talk because we're talking pain now, and this is
Yeah.
one of the most important pain relief after major abdominal surgery. So you might touch this block as well. I'm assuming. Let's
Yeah.
see. Please
Uh,
carry on.
thank you,
Thank
Doctor.
you.
Thank you, Doctor, for your kind introduction. I'm very humbled by such an introduction. Today, I'll be discussing pain relief for major abdominal surgeries. What I'll be concentrating on is on a few concepts. I'd like just to start by declaring that I do not have any conflict of interest. I will just have a quick introduction about the concept multimodal analgesia and where do we stand right now in the era of ERAS. Then I will be discussing the concept of multimodal opioid sparing analgesia. And we will move on to discuss few points about opioids and what the challenges do we have currently with opioids and some of the opioid sparing strategies and medications that we can use for reducing the doses of opioids and reducing its related complications. I will touch on thoracic epidurals, paravertebral. I don't think I will be talking about rectal spinal plane block after Dr. Yasser's lecture, but I will be touching on transversus abdominis plane block and quadratus lumborum blocks in terms of pain relief when it comes to the different procedures. So with the multimodal analgesia, we all know that multimodal analgesia is one of the most important methods to reduce the doses of opioid or even to achieve a better analgesia. For example, in Lambert study, when he compared weak opioid, tramadol at the time, and NSAID and paracetamol, when he compared them to hydromorphone, he has found that the multimodal analgesia has provided the patients with better pain control, better satisfaction. And in the current studies or in the current randomized clinical trials that's looking at multimodal analgesia in the setting of ERAS protocol, they have found that that model is still providing better pain score, better satisfaction for the patients, faster recovery and shorter length of stay in the hospital, as well as less respiratory complications. The issue is not with the multimodal analgesia as much as with implementing the multimodal analgesia. And that is why implementing a standardized clinical assessment and management plans are paramount. For example, if we look at a recent survey, a recent national survey that has been done here in the United States for 52 hospitals, they have showed that hospitals varied significantly when it comes to the post-operative plans, as well as with the success rate of that post-operative plan management. So just let me bring out the tables from this study here. This is a study that has looked at the post-operative pain score in different hospitals after colorectal resection surgeries. And they have divided the hospitals in four categories, depending on how good those hospitals were in terms of controlling the pain for their patients. What they found is that, and let me zoom in here, they found out hospitals with better pain scores seems to be doing much better in terms of complications, and they have some sort of some characteristics that combine them. For example, hospitals with better pain scores seems to be doing more minimally invasive procedures, as well as having a higher volume when you compare them to the lower performing hospitals. But what's important for us as anesthesiologists is that how did they provide the analgesia for their patients. If you can see here, hospitals that have used, for example, epidurals tend to have better pain scores when you compare them to hospitals that that did not do so. Also, not just epidurals, the use of other analgesics. And if we look here, the use of multimodal analgesia was around 70% of the time. Now, this number is actually low for what we should be aiming or what should be achieving for. But you can see that when a hospital uses, for example, a multimodal analgesia model, that would include for epidurals, opioids, and NSAIDs. And in different methods, they would produce better pain scores when you compare them, for example, with hospitals that do not use. And even for a single procedure, hospitals, like for example, the hospitals that are on the lowest tier score have used epidurals as much as the group that has produced better pain score, but they have used much less, for example, non-steroidals when you compare them to the other group. So the combination of the medication does matter significantly. And in terms of complication, it's a similar story. Hospitals with better pain score, for example, had a lower overall complication rate when you compare them to worst performing hospitals. They have a lower length of stay. Here, for example, the patients stayed around 6.5 days when you compare them to the lowest performing hospitals, where the patients would stay around 8 days on average. And that's around just 2 in terms of standard, in terms of deviation of mean pain scores. The rate of complications respiratory wise was significantly lower in the better performing hospitals when you compare them to the worst performing hospitals. And this emphasizes on the need for implementing some sort of standardized method to try to make sure that our physicians, whether anesthesiologists, surgeons, or other sort of physicians, trying their best to implement, whenever feasible, a proper multimodal analgesia model. The other important concept here that we have to discuss is the concept of procedure-specific pain control. The thing is, and the concept of the thing is, if we compare, for example, the efficacy of analgesics, we will find that their efficacy varies significantly depending on the type of procedure. For example, in a recent study by Dr. Gray and his team that looked into the efficacy of paracetamol among different procedures, they found that paracetamol was so more effective after dental procedures and was least effective after orthopedic procedures. Similar study was done on non-steroidal anti-inflammatory medication, and they've shown that it's more effective in urologic and orthopedic procedures than after, for example, thoracic procedures. Moreover, we all know that opioid requirements differ significantly by procedure. This is something as anesthesiologists we see basically every day. When we look at major abdominal procedures here, for example, in 2019, a study by Dr. Lin and his team has showed that the use of PCA IV opioids after in the first 24 hours after abdominal surgery was highest among patients who underwent open pancreatectomy when we compared them to other procedures, where it was the lowest among patients who underwent open hysterectomy. The difference was so big that it's almost double the dose of daily opioid. Open pancreatectomy through their analysis have shown to need around 77 milligrams of opioid of morphine on that specific day when you compare it to hysterectomy. And this is why the need to develop procedure-specific guidelines has become more paramount and urgent. And this has led to the development of Prospect. It's basically a short for procedure-specific post-operative pain management initiative. That's here, their website. You can access it easily through the European Society of Regional Anesthesia. And let me show you a snapshot of how it will look like. So this is how the website would look like, and it will target the pain management plan for every and each procedure. There isn't that many procedures to develop plans for. That's mainly because of the lack of research in that specific manner. We are still more concentrated on the general approach of post-operative pain rather than approaching it from a procedure-specific manner. If you go onto their website, and let me zoom here, you can see that they will be providing you with the current level of evidence as well as some sort of algorithm to help the physicians in developing their plans for that specific type of procedure. Now, let's start with opioids. And for decades, basically, opioid has been the main pharmacological agent for moderate to severe pain. And we all know that around 80% of the patients who undergo surgery require opioids during their stay. Opioids,
Dr. Mohammed, can
yes,
I ask you, please,
of course, Dr.
would you be kind to come back to the slide of the European Society? That one, please.
Yes, right. Yeah. The link, I have it here in my presentation. It's in
Before,
the
yeah.
it's the European Society of Regional Anesthesia Europe.org/prospect. So the target of this is to look mainly for pain management, to develop pain management plans and recommendations for specific procedures. Like, for example, pain management plan for laparoscopic sleeve gastrectomy, pain management plan for open colorectal surgery. This is very, very important, especially when we compare the efficacy of medications in different categories. For example, after laparoscopic cholecystectomy, gabapentinoid seems to be not effective at all. On the contrary, they seems to be increasing the complication rate. But after, for example, when you compare them, for example, to open hysterectomy, they provide a significant opioid sparing effect. They reduce the length of stay in the hospital. Those two procedures are basically abdominal in nature, but they yet behave quite differently. Radical prostatectomy is also another lower abdominal procedure that gabapentinoid, for example, do not seems to be providing any sort of improvement on the multimodal or the multimodal analgesia model when we compare it to abdominal hysterectomy. Although incisions are to some extent slightly similar, the location is slightly similar. So the need here for procedure specific plans is important, because pain management do not work the way we used to think about it. It does not work from a location perspective, rather than it works from a procedure or a disease, more of a disease perspective. Going back to opioids, as I said, the problem with opioid is that they are effective, but the issue is their efficacy and their complication are more or less in a dose-dependent fashion. Opioid has many complications, as we all know, and that includes, for example, sedation, respiratory depression, nausea, vomiting, which is quite common with the use of opioids. Opioids also leads to a delay in the GI function and the recovery of the bowel function. They lead to urinary retention, and chronic post-operative opioid use is currently a big problem, especially in the era of opioid crisis. The chronic use might lead to opioid abuse disorders. And it might as well lead to some sort of opioid dependence. If we look, for example, here with the current opioid crisis, there's a significant need to overcome that sort of problem of post-operative opioid use. Let's look at the abdominal surgeries here and chronic opioid use. And for example, patients undergoing uncomplicated colorectal surgeries, around 15% of the patients would require post-opioid discharge. That's a massive number, and we're talking here about more than 1 month of use of opioids after uncomplicated colorectal procedures. If we look at this graph here, if we looked into the opioid prescription, and this is basically looks at the opioid prescription after abdominal surgeries, only a very small number of patients tend to stop their use of opioids after the surgery. The light graph here, or the light column, shows the percentage of patients who were using opioids preoperatively. And the black graph here shows the patients that started using opioids after the surgery. And around 22% of the patients seems to continue to use the opioids even after 6 months of their procedure. Only very small number has stopped using their opioids, and the surgery itself has added some proportion to the patients whom they continue to use opioids for more than 6 months after the surgery. A more scary graph is if we look at the incidence of post-operative opioid overuse after abdominal procedures. You can see that this graph is dramatically increasing year after year. Here, for example, that put us at a very important fork. We have to know what are the risk factors that that leads to that such prolonged post-operative use. Procedure specific is one of them. After abdominal and thoracic procedures seems to be having a high risk of incidence for patients to develop chronic post-operative use. Open procedures seems to have a higher impact when we compare them to minimally invasive procedures, for example, at the rate of developing post-operative use after 1 year. Now, the most significant risk factor was in most of the studies was the preoperative opioid use. Preoperative opioid use seems to be as the single most important risk factor to predict the prolonged post-operative opioid use. Acute pain, especially severe acute pain in the early days, seems to be a predictor of chronic post-operative use, and this put us in an important, this gives us an important task to properly control the post-operative period. Chronic post-operative pain also is one of the factors that might lead to post-operative pain. Another important factor is young age. Younger patients seems to be more prone to continue their use of opioids on the long term. Patients who are dependent on tobacco or alcohol also has a higher risk of developing prolonged use of opioids. Depression, anxiety, and perioperative use of benzodiazepines are also significant factors. So we can see here that there's the quite wide range of factors that might lead to such post-operative use. So the next question will be is how can we deliver that opioid to the patient in a manner where we can reduce that sort of complication, whether it's dependence, constipation, length of stay. And so I will start with comparing the opioids, IV opioids or nurse-controlled opioids with PCA. Thing about PCA is that they do provide better pain control. Here, this is a first plot from Hudkova's Cochrane review, and you can see clearly that PCA does provide some sort of pain relief after lower abdominal surgeries. But the problem is for upper abdominal surgeries, when you compare PCA to intermittent nurse-controlled IV opioids, it doesn't seem to be providing a better result. The other thing is about PCA, and most of the people were advocating to use PCA, is that PCA will provide the patient with the proper amount of opioids that this patient would need to overcome the complication. But what happens in reality is that patients use more opioids when they are on PCA to achieve the pain control. And what ends up happening is those patients, even with lower abdominal or upper abdominal surgeries, they tend to have more constipation, although their pain is similarly to some extent controlled. Another complication that seems to be the same is sedation. Sedation does not change whether you use a PCA opioid or an IV opioid. And sedation or respiratory depression is most significantly associated with sedation. So whenever we use PCA, we should always be careful that this complication is still there and the risk of respiratory depression is still there. Nausea and vomiting, on the other hand, PCA did not improve the use of nausea and vomiting, and it's almost similar, whether that's an upper abdominal surgery or a lower abdominal surgery, when we compared it to an IV opioid. So what other method? Well, intrathecal opioids. The use of intrathecal morphine has significant opioid-sparing effect. If we look here, let's look here at the right side of the screen. The group A, for example, shows the opioid consumption after 24 hours after the surgery for patients who have received intrathecal opioids, while the second group here showed the 48-hour post-operative use of opioids after the surgery. Now, you can clearly see the lift shift of the graph here in favor of the opioid sparing effect of intrathecal opioid. The thing we have to keep in mind is that the risk of opioid-related complication is still present. Incidence of pruritus, for example, seems to be higher. And let us zoom in here further so we can see it more clearly. The incidence of pruritus, for example, is around 4.3 times than the incidence with the IV medication. Respiratory depression is actually 5 times higher when we use larger doses of IV or intrathecal morphine. The incidence becomes significantly similar is when you use low doses of IV intrathecal morphine. Doses less than 500 micrograms of intrathecal morphine produces similar risk of respiratory depression when we compare them to IV medication. But higher doses, the dose of 1 milligram that's most commonly used, produces around 5 times the risk of complications when it comes to respiratory depression, without providing a significant improvement in terms of analgesia. So we always have to keep in mind when we use intrathecal opioids that those effects are still there. Looking at the multimodal opioid sparing analgesia, because of all those complications and issues with opioids, reducing our dependence on opioid is actually paramount. In this graph, we can see a lot of options that can provide the patient with opioid sparing effect. But nowadays, experts are using and advocating for the use of multimodal opioid sparing analgesia, where we'll be using multiple methods to overcome the problem of analgesia and properly providing a better control. NSAIDs work nicely. Glucocorticoids like dexamethasone have shown some evidence in reducing the opioid sparing effect. Acetaminophen and paracetamol, as we all know. NMDA antagonists, ketamine and magnesium, have shown some evidence in support. Dexmedetomidine, in similar way. Intravenous lidocaine have also showed some promise in their opioid sparing analgesic effect. Gabapentinoids and regional anesthetic techniques, whether it's a neuroaxial analgesia or the peripheral nerve blocks. So looking at gabapentinoids seems to be having an opioid sparing effect. It improves the post-operative nausea and vomiting. In some studies, it is showed that it reduced pruritus, preoperative anxiety. It has shown that it has reduced the patient satisfaction. After abdominal hysterectomy specifically, gabapentin, for example, reduces post-operative pain and total morphine consumption. And it has also shown that it to reduce morphine-related complications. But the problem is gabapentin in colorectal surgical population, for example, has been associated with a higher use of non-invasive ventilation and a higher use of naloxone to overcome that respiratory depression. What seems to be in a cycle where gabapentin is providing a synergistic effect for the opioids. There is still no consensus on whether pregabalin or gabapentin are superior. For example, for abdominal hysterectomies, some RCTs are suggesting that pregabalin might be superior. If we look here at two reviews, one by Dr. Wang and his team in a meta-analysis in 2011, and the other one, which is, I believe, is an excellent review by Dr. IP and his team. The first review has found that pregabalin does not produce any effect when it comes to the pain control. Mainly, it has an opioid-sparing effect. While in the other study, they have shown that it produces a better analgesia and opioid-sparing effect with a reduction in nausea and vomiting, but they have noticed that it increases the risk of sedation. All of those studies are done on abdominal surgeries. Looking here at this graph, for example, and this is the effect of gabapentinoids on different type of procedures by Dr. Arkumam. And you can see here that abdominal hysterectomy, in abdominal hysterectomies, the use of gabapentins or pregabalins have reduced the opioid consumption quite significantly. But that is not the case for cesarean section. Cholecystectomy here has a proper effect, for example, but prostatectomy does not produce a similar result. So we have to keep those mechanisms in our mind when we use such medication and when we develop plans for our patients. In this graph, for example, we see the incidence of nausea and vomiting after abdominal surgeries for pregabalin. It seems to be that the dose of pregabalin might play a mild role here in the reduction of the incidence of nausea and vomiting, with doses around 150 showing mild shift to the left of the graph, while doses around 300 milligram daily seems to be producing a more significant effect. If we look at this graph here, or there are two models here. The first model looks at pain during movement for pronoceptive pain, for pronoceptive type of pain, or pain that produces hyperalgesia. And here that pain that's not related to hyperalgesia, and pregabalin does seem to significantly reduce the pain that's mainly pronoceptive in nature when you compare it to a non-pronoceptive type of pain. Now, one interesting complication that has seemed to be rising with the use of pregabalin, and that seems to be increasing whether we use it in lower doses or high doses, but seems to be more prominent in patients who are opioid naive, is the risk of blurred vision after the use of pregabalin. Here we can see also the effect of gabapentinoids on sedation, and that effect seems to be whether we use a lower dose or a higher dose daily basis. Moving to lidocaine. Lidocaine, as we all know, is a local anesthetic and an antiarrhythmic that works mainly through its effect on the sodium channels. But the problem is how it does work in an IV form. Dr. Van der Waal has suggested that this medication might have an effect on the calcium channels, sodium channels, potassium channels, as well as modulation at the NMDA receptors. Intravenous lidocaine specifically has a high level of evidence when it comes to abdominal procedures. It has been shown to improve pain consumption and reduce opioid consumption in open and laparoscopic abdominal surgeries in multiple studies. It has shown also to increase or reduce the duration of bowel dysfunction and improve the time for a first bowel motion. And it has seemed also to improve the length of stay in the hospitals. And it has been shown also to prevent hypersensitization and hyperalgesia in abdominal surgeries. And there is quite the evidence that it has some sort of anti-inflammatory properties. And this has been more significantly pronounced with their use intraperitoneally. Intraperitoneal use of lidocaine have shown also to reduce inflammatory markers after colorectal procedures. In abdominal surgeries in general, there has been no report of life-threatening or major arrhythmias with the use of intravenous lidocaine. The problem comes with its dose. There's still no consensus on what is the optimal dose for intravenous lidocaine, although most experts tend toward the 1.5 milligram per kg per hour, but still there is no specific consensus on what is the best dose for abdominal procedures. Intravenous lidocaine have shown to increase the incidence of drowsiness, perioral numbness, and nausea in the abdominal surgery population. Another medication is dexmedetomidine. Dexmedetomidine is an alpha-2 agonist that has sedative and analgesic properties. And it has been shown that dexmedetomidine reduces the post-operative opioid use in a few surgeries, mainly gastrectomies. Open gastric surgeries and upper abdominal surgeries seems to be benefiting the most from dexmedetomidine. Abdominal hysterectomies there is a good significant of evidence to support their use in abdominal hysterectomies as well. But colorectal surgeries, dexmedetomidine did not show any evidence that it's better than the other analgesic options, or does not seem to be even better than IV lidocaine, for example. There is evidence to support its faster GI recovery after surgeries. But the problem again is the doses vary significantly among studies. Still, the major side effect from dexmedetomidine is cardiovascular depression, mainly in the form of hypertension and bradycardia. But the dose plays here a major role. The higher the dose, the larger the risk. Magnesium sulfate and an NMDA receptor antagonist in the form of IV have shown also some evidence to provide a very good opioid sparing effect. You can see a significant shift of the forest plot that has been presented by Dr. Oliveira 2013 for the reduction of opioid consumption. Magnesium sulfate is on its own is not as strong analgesic, but when you combine it with the other medication, it produces a very good opioid sparing effect. There has been no reported major related side effects from the use of IV magnesium sulfate in abdominal procedure population, but it does not seem to be reducing the opioid-related side effects, mainly nausea and vomiting. Moving to thoracic epidural analgesia, well, thoracic epidural is well recognized as a superior analgesic choice when it comes to PCA, opioids, mainly for major abdominal procedures. And that effect becomes more significant when we talk about the pain control during movement for the thoracic epidurals. Pain control at rest when we compare epidural to PCA is slightly better, but when it comes to movement, it's significantly better. And thoracic epidurals are currently advocated in the ERAS protocols for colorectal procedures and mainly most of the abdominal procedures. Let me zoom in here to make it clearer. Thoracic epidural seems to be improving the function of a return of the function of the bowels, especially after gynecological procedures here, after colorectal procedures, open colorectal procedures, and after urologic procedures. But that effect doesn't seem to be after cholecystectomies, for example. The thing is, we have to keep in mind is the duration of the thoracic epidural. Thoracic epidural during the surgery alone does not seem to be providing a better effect when it comes to the return of function for the bowel. But when we keep it for more than for around 48 hours to more than that, the effect becomes more pronounced. And that's when it contributes to a better post-operative period and improvement in the quality of the patient analgesia and return of function. Paravertebral block seems to be an alternative choice to thoracic epidural, especially if it's used bilaterally. The ultrasound technique has helped to improve the success rate and ease of performance quite significantly. For example, in a study in a recent study in 2019 that has compared the paravertebral block with the thoracic epidural for midline abdominal incision, it seems to be that bilateral paravertebral blocks are non-inferior to midline to thoracic epidurals for midline abdominal surgeries. And but we have to keep in mind that if we go for a blind technique, paravertebral block success rate for the first attempt is around 70%, which means that 25% of the time your paravertebral block will not be in the proper place. While if you use the ultrasound, the success rate goes up to 94%. In some RCTs, they have reported that the failure rate of the paravertebral block with the use of the ultrasound is around 0%. So let's look at the paravertebral block and we compare it to different techniques in different procedures. For hernia repair surgeries, when we compare the paravertebral block to the transversus abdominis plane block, for example, there doesn't seem to be any difference up to 72 hours after the surgeries. The only period where paravertebral blocks seem to be superior is in the first hour. For laparoscopic cholecystectomy, as we said, that when we compare paravertebral block to IV opioid, paravertebral block seems to be effective only in the first few hours. But that effect does not last for more than a couple of hours. For open cholecystectomy, the story is slightly different. When we compare it to the thoracic epidural analgesia, the analgesia from paravertebral block seems to be equivalent in the first 24 hours. But after that, this analgesia, the difference becomes much more significant toward thoracic epidural. And this mainly seems to be due to how the medication flows with the infusion when you in the paravertebral place when you compare it to the epidural place. For hepatectomies, for example, paravertebral block seems to have a significant benefit in the first 24 hours. But when you compare it to PCA morphine, after 24 hours, the results are similar. So this advocates the use of some sort of an infusion for the paravertebral blocks. Open renal surgery, also similar results. Paravertebral block is superior only for the first 24 hours. For gynecological procedure, on the other hand, now bilateral transversus abdominis plane block or paravertebral block both seems to be effective for up to 72 hours. The improvement of the paravertebral over the TAB block is just very modest. And this has been done by Dr. Al-Baghdadli's excellent review on the effects of paravertebral blocks per procedures. Now, now let's move to the transversus abdominis plane block. Transversus abdominal plane block seems to be effective, especially for the lower abdominal surgeries. In this graph here, we compare the transversus abdominis plane block to the thoracic epidural after open or colorectal procedures. And you can see that surgeries with a lower abdominal incision, the transversus abdominis plane block does not seem to be different or significantly different from thoracic epidurals. But when we compare them to upper abdominal incision, thoracic epidural seems to have a significant improvement compared to the paravertebral block. But the thing is, TAB block seems to be providing a faster functional recovery and faster ambulation time and a shorter urinary catheterization time, which put us in a situation where we have to overthink our approach to open colorectal procedures. But which approach to the transversus abdominis plane block is better? We know that there are multiple approaches. The lateral approach is where we inject or we approach the transversus abdominis plane at the mid-axillary line. There is the posterior approach, or what's currently more commonly known as the quadratus lumborum block, where we approach the transversus abdominis plane at the angle of PT. And there is the subcostal and the ilioinguinal at the anterior iliac crest approaches. Now, for lower abdominal surgeries, both procedures, the lateral and the posterior TAB block, seems to be effective in a similar fashion up to 36 hours. The main difference comes after the 36 hours. At 48 hours, posterior TAB block seems to be superior to the midline or lateral transversus abdominis plane block. And here, when we compare it, when we compare the transversus abdominis plane block to the quadratus lumborum, most of the RCTs are suggesting that quadratus lumborum seems to be providing a better analgesia for surgeries of the lower abdominal with lower abdominal incision, and mainly for a longer duration. There is also some evidence to support that quadratus lumborum block also produces some visceral pain relief. After cesarean section specifically, quadratus lumborum is showing a significant improvement for up to 72 hours. For rector spiny, I don't think I'll be able to add anything after Dr. Yasser's presentation. And before I conclude, I just want to bring to your attention where are we right now in 2020 in terms of post-operative pain control after colorectal surgery. If we see here at this graph in the middle, 50% of the patients still have around some sort of moderate to severe pain, even in the era of ERAS and multimodal analgesia. Post-operative day 1, day 2, or day 3 do not improve this story. Moderate to severe pain actually increases in those areas. And if we look at the age to pain score, it seems to be that the younger the age, the worse the pain in those patients. Let me zoom in this graph and show you just a few examples or differences between the procedures themselves. The blue line here represents open surgeries for open colorectal resection, and the red line here represents minimally invasive procedure. On the first day of surgery, open surgery seems to be better pain controlled. This is most likely related because we use more medication, and we use the epidurals and the regional techniques during the first day of surgery for those patients. That graph changes later on, and this is almost universal. If we look at the colonic resection, it's the same trend. If we look at the abdominal perineal, for example, rectal resection, it shows also a similar trend. So minimally invasive surgeries are not less painful when you compare them to the open surgeries if we do not treat them properly. My take-home message here is, as anesthesiologists, we should always work hard to improve the quality of care we are providing to our patients. And we should work hard on implementing some sort of standardized pain management plans to make sure that we improve the compliance with the multimodal analgesia model. We have to make sure that our plans are more or less procedure specific to achieve the best results that we can achieve. And also, we have to make sure that we individualize those pain management plans according to age, for example, and to the patient population. And keep in mind that multimodal analgesia has to include some sort of multimodal opioid sparing analgesia. Thank you very much.
Thank you very much, Dr. Nobani. Can you hear me?
Yes.
Yes, okay. Thank you very much. Now, I only received compliments for you and Dr. Yasser in the chats. And before I thank you all, because I know the time is running very short, your presentation is very comprehensive in terms of providing evidence, although there are some small sort of charts which has minute information, but this is a recording, so people can see at their leisure, and you explain very well your little slides. So my question is only, are you actually practically doing anything in your workplace to help produce some plans for procedure-specific surgeries and prevention of chronic post-surgical pain, which is a very, very important issue? Why do we treat pain? Humanitarian, yes, we must do it. Number two, now the emerging evidence is the not so well treated pain, not so well managed pain can cause a huge burden on the economy and the person and the field of sort of medicine into chronic when it turns into a chronicity. So are you thinking a plan, literally a plan, as in as a program to prevent those and manage pain?
Yes, I couldn't agree more with your statement, Dr. Khalil. Currently in Hamad, we are trying to implement some plans for specific procedures in the orthopedic. And I think, as Dr. Yasser know, that we have been working hard on those type of plans. We have been working on hip patients who undergoes hip surgery, for example, patients with hip fractures, patients with tibia plateau fractures. But still, there's a lot of work that's needed. There is some significant work that has been done when it comes to pain after breast surgery in our institution, but there is still a massive amount of work that has to be done. Also, a lot of research is still needed in that field to properly formalize the most effective plans for such patients.
Yeah, my 2 cents for everyone is actually whoever is doing pain is the basics of pain, not the basics of pain management. But if you are grounded your management, if you're grounded really in the pathophysiology of pain, so you must spend some time in teaching or in sort of discussing and producing good lectures and good practical sessions linking the pathophysiology of pain with the management. Like you travel with your fibers and with your
Nah,
medicine in the patient's body. So that is my obsession actually. But I see you guys are
I
doing
couldn't
very
agree
well.
more.
So that's the one end of the stake, but you pick up the stake from the very basic thing. So I have received some raising hands. One thing I like to acknowledge that amongst the participants, we have professors, we have eminent names, lecturers, and the names I have noticed actually in the past in presentations and publications, and they're very paying compliments to you as a speaker. So I'm thankful to
Thank
the
you.
participants, really. The credit goes to the participants for staying with us for the last 2.5 hours. And the talks you presented, all of you, Dr. Nabil, a very novel, very expert talk, Dr. Yasser as usual, a very engaging and very motivating, very enthusiastic talk. And yours is an evidence-based talk, which is one of the most important topics and very close to everybody's heart. So I think those talks were very well taken by the participants, and they are sending messages of compliments to you. So thank you very much to all of you. And Dr. Saad, thank you very much for hosting us from Doha, Qatar. And hopefully we will see you next time with you can engage us more on other presentations as well.
As you mentioned, Dr. Khalil, I'm very humble tonight, and I'm really very overwhelmed about this webinar. The amount of science and education and teaching here tonight is extremely paramount and beyond my expectation. I would like, before, as you mentioned, I would like to thank all attendees and all professors and all senior colleagues staying with us till this time now. My thanks to our speakers, Prof. Nabil, Prof. Yasser, and my excellent colleague, Dr. Mohammad Nobani. Dr. Khalil, special thanks for you and the chairmanship of this session, which you made it live, really. You know, you give it live and you give it power to be a model moderator. I think you made a very hard job for the other people to come after you to be moderator. And I believe that is very competitive job now, you make it a real function, and really I'm overwhelmed. I'm very emotional about this webinar. Beyond the, that mega online course can make you learning, teaching, moderating without moving an inch from your place. So from Qatar, from Houston, from Ireland, from Egypt, from India, from Pakistan, all of this around one table here, mega online course. And tonight, especially, mega Qatar online course. And thank you very much for Dr. Nabil for suggesting that the name of this webinar tonight. A special thanks for my excellent professor, Prof. Khalid Radwan, who is supporting us tonight, and Professor Mona Abu Saud, Professor of Endocrinology in Alexandria, Egypt. I will leave the conclusion for you, Dr. Khalil, to close down the session. And special thanks for everybody from my heart.
Thank
Thank
you.
you.
Thank you very much, Dr. Saad.
you.
As I earlier on mentioned that my special thanks actually that goes to the participants. And I'm
you.
overwhelmed with the participants actually. They were about more than 200. Not only that,
Exactly.
when I looked at the quality of people present amongst the participants, that gives us an oomph to sort of, to go ahead with further maybe in the future talks. So Dr. Nabil Nobani, Dr. Yasser, they all are very, very practical and very expert colleagues of mine. And in Qatar, they are doing a very great job in these areas, I must admit. And
I'm
they are,
looking forward to have
yeah,
you, all of you, again and again, and extend our
the
knowledge
training.
and experience, because I believe the comment tonight I have seen on Facebook and here in real life in the webinar is extremely overwhelming and encouraging. So I have much more responsibility now to get you back, as soon as possible.
Thank you very much. Can I
Thank
say
you.